We're excited to have you join us today and thankful for our leading sponsor, ClearSense. Let's start with why. Why are we launching this program? Most hospitals aren't set up to engage with startups, and most startups don't know how to partner with hospitals. COVID-19 has changed the game. Now hospital executives see what is possible and quickly and effectively problem solving through removing these types of roadblocks. As a startup advisor, investor, and recovering patent attorney, I'm keenly aware of this problem. This program is all about real problems faced by hospital leaders and how they solve them in partnership with emerging technology companies. Today, we're focusing on the partnership between UT Health Austin and Sentinel Healthcare to address contact tracing and home monitoring. Our speakers, Erin Miri, CIO, UT Health Austin and CHIME member, Dr. Liz Jacobs, Chief of Primary Care, UT Health Austin, and Dr. Nirav Shah, CEO and founder of Sentinel Healthcare. Time permitting, we'll take questions at the end, so please submit any questions in the Q&A tab. CHIME members are welcome to join the behind-the-scenes session immediately following this webinar. Please exit the webinar and join the separate Zoom meeting. David Chow, CIO of Harris Health, will be our moderator, with additional guests, Dr. Darlene Bhavnani, Global Health Specialist, UT Health Austin. Also, this session is being recorded and will be available on demand viewing. With that being said, I'm going to hand it over to our leading supporter, Chris Jordan, VP of Customer Success at ClearSense. Chris, please take it away.
Thanks, Jonathan, and thanks everyone for joining us today. As Jonathan mentioned, my name is Chris Jordan, and I'm Vice President of Customer Success at ClearSense, where we provide a holistic data platform as a service that helps providers achieve their data maturity goals. We're honored to be sponsoring today's speakers, Erin Miri, Dr. Liz Jacobs, and Dr. Nirav Shah. Erin Miri is the CIO for the University of Texas at Austin, Dell Medical School, and UT Health Austin. Erin brings more than a decade of healthcare experience driving growth and innovation, leading both provider and commercial healthcare enterprises. In 2018, Erin was congressionally appointed to the Health and Human Services Federal Health IT Advisory Committee. He's also the prior chair of the HIMSS National Public Policy Committee and serves as an expert advisor to the United States Senate Committee on Health, Education, Labor, and Pensions, and to other congressional panels engaged in numerous health IT policy topics. Dr. Liz Jacobs is Chief of Primary Care and Value-Based Health and Professor of Medicine and Population Health at the University of Texas at Austin Dell Medical School. She also serves as Associate Chair for Research in the Department of Internal Medicine. Liz is recognized as an expert on developing accessible and culturally competent care for diverse populations. And at Dell Medical School, she works to establish a patient-centered, value-based academic primary care program. This includes creating and disseminating new models of care, developing and creating innovative curricula in primary care, and creating an environment that supports practice-based research. And finally, Dr. Nirav Shah is co-founder and CEO of Sentinel Healthcare, a digital health company providing the first comprehensive remote monitoring solution for hypertension. A practicing neurologist, he formerly served as the stroke director of Swedish Neuroscience in Seattle, the largest stroke program in the Pacific Northwest. Nirav was inspired to create Sentinel based on his experience treating patients who suffered heart attacks and strokes caused by uncontrolled blood pressure. So to get us started, I'll hand this over to Erin, Liz, and Nirav.
All right, good morning, everybody. Thanks very much for joining us. I'm really pleased to be here and to be able to talk to you guys about a problem that we solved here, or we're solving still, at UT Health Austin here at the University of Texas at Austin. Let me give a couple minutes to Dr. Jacobs and Dr. Shah to introduce themselves. Liz?
Yeah, good morning, everyone. I was delighted to have the opportunity to work with Sentinel and Dr. Shah and his team and Erin Miri here at Dell Med to be able to develop this innovative solution to a problem we faced around home monitoring, and then working with Darlene Bhavnani around contact tracing in an efficient manner.
Thanks, Dr. Jacobs. Thanks, Erin. Thanks, CHIME and InnoCast. I'm also delighted to be here. I'm Nirav Shah, founder of Sentinel and a stroke neurologist by training. And it's been a real pleasure working with the Dell Medical team on this bittersweet problem, COVID, but then also providing a unique solution to it.
Fantastic. All right. So hopefully everybody is seeing my screen. All right. So we're going to go into it now. So we are also joined by David Chow, who's the CIO at Harris Health. I don't know, David, if you're on. He is on. He may be on mute. All right. Well, David is also on as well, and he will be moderating us later on for the Q&A portion. But let's get into it. All right. So quick facts about Dell Med and UT Health Austin. Relatively new, obviously in the academic medicine space. That's sort of unheard of, which was a fantastic challenge to come here and start something new. So opened up 2016 and 2017, the clinical enterprise was launched. Multidisciplinary ambulatory practice, multi-specialty physicians that then practice and perform surgery and all sorts of medicine at the various hospitals here around Austin. I primarily with the Dell Seton Medical Center, which was also opened in 2017 as a level 1 trauma hospital, and is also our teaching hospital. And then of course the Dell Children's Medical Center, which serves all of Central Texas, and it's an acute care pediatric teaching hospital as well. So we were really fortunate here in Austin to be able to have this footprint and a type of caliber of physicians. So when this problem hit, we were able to jump right into it. So let's start talking about that. So the COVID-19 problem, all right? On March 4th of 2020, COVID-19 officially became a Texas problem. We had our first Texan diagnosed with it. Governor Greg Abbott declared a public health disaster on the 19th of March. At that point, our clinicians and our physicians were already geared up in the fight. We leaped in 2 feet first. About mid-March, we became operational with dealing with the COVID-19 situation with drive-through testing. And then we can talk a little bit more about home monitoring component was stood up, and a major telemedicine care delivery, as many of you across the country have had to experience. It was probably an overnight thing, as it was for us, to suddenly shift to almost 100% virtual care. At the end of 2020, or end of March 2020, we decided then to start looking at other modalities, and specifically contact tracing, in which case then in April, Austin Public Health formally asked us to start looking at how to deliver contact tracing. And then of course we went live with that around May timeframe. Dr. Jacobs, I don't know if you want to articulate the problem from a clinical perspective.
Yeah, I think what I would add is that as we experience this pandemic, it's really important to keep people out of the community and out of healthcare settings who might have COVID. So that was one of the goals of the home monitoring program, was to be able to give people guidance around their symptoms, et cetera, as to how they could manage them at home, and give them great advice on where they would want to go if they were having increasing symptoms, so that we could not overload the hospitals, emergency departments, and clinical systems. So that was one of the reasons why we developed this program. And then for the contact tracing side, one of the things that's a potential for what we worked out was that we could also monitor the symptoms of cases and their contacts, and give actually information to those people who develop symptoms, if they're a contact, about where they can get tested, and also give them advice. So having an integrated home monitoring and contact tracing system, as Sentinel could provide, actually was can be very valuable, and has been very valuable to us.
And so when the problem was presented, as for any of the CIOs in the audience listening, it was, hey, we need to be able to start doing temperature monitoring for patients at home that have either come through our drive-through testing or suspected, to make sure that if their temperature begins to get out of range quickly, that we can identify it, we can get in front of it, we can contact them, we can advise them to come into the emergency department. And so, all of us started talking about, well, are there solutions on the market? And COVID was so new to the United States that no, there weren't at that time. Now you have solutions from Epic and others that are kludgy at best, but there was absolutely nothing. And so in leaps a fantastic company, out of the Pacific Northwest called Sentinel to help us. So with that, we said, okay, how do we go about this, right? Do we build this out? What do we do? Come to find out, Sentinel was already doing this in 2 markets, and Dr. Shah can speak to that here in a moment. And it started looking like, okay, maybe this is something we can bring to Austin. Let's have a clinician-to-clinician discussion in which Dr. Jacobs and Dr. Shah and numerous other doctors that we couldn't represent all of them on this call join in and having these conversations saying, could this be something we could roll out quickly to the city of Austin? Liz or Nirav, if you want to speak to that.
Oh yeah, I just wanted to add one other thing that I actually left out in my previous comment, which is that one of the great things about this solution is that you don't need it's not personnel heavy or clinician heavy need, because you can have people monitoring the dashboard, which you'll see later. You don't have to call people on a daily basis if they're logging their symptoms and their temperature. So it also is a really efficient method for following people.
Dr. Shah?
Yeah, thanks for all the comments. Yeah, I mean, and so given that we're based in Seattle from a tech perspective and our tech team's here, we saw the first case towards the end of February. We'd also seen colleagues and friends in Asia start kind of sharing news early in January and February. So we knew that it might be coming. And even despite that, I don't think we realized how significant it would be. So on March 1st, we internally decided to start working on this. Prior to all this, we were working on cardiovascular monitoring, hypertension, for post-stroke, post-heart attack, and general primary care issues. But given that we already had the platform for blood pressure monitoring and cardiac monitoring, it was relatively easy to extend it. It took us 9 days to stand up sort of a new app. Aaron and Liz and the team at Dell helped us work with Apple and Google Health directly because there were some issues around predatory kind of apps cropping up in the app stores. And so we were able to get through that process in just a few short days and then start going live with the more resilient cloud to mobile solution for both the monitoring as well as the contact tracing, which took a little bit more development. But we already had an architecture to help patients monitor themselves and work alongside their family members. That architecture that we call caregiver mode enabled us to kind of extend this for the purposes of household isolation and quarantine contact tracing.
And it was interesting because at the same token that we're doing the tech side, you're also building out your operational processes. And so I give a lot of credit to Dr. Jacobs and a huge team that was supporting this to figure out, okay, how do we do this, right? What is the process for it? What temperature and what duration do we, elevate standards to say, okay, hey, you need to come in, or we need to send someone to you, or you need to be advanced to our nurse triage line. So there's a tremendous amount that goes with a piece of software that's all about process and process improvement. And Dr. Jacobs spent a tremendous amount of time with especially some of our clinical informaticists and others to map all that out. So I don't want to overlook the fact that, it wasn't just like, hey, buy a piece of software, slam it in. There's a ton of process behind the scenes just to do home monitoring, much less we'll talk about contact tracing in a second. But I don't know, Dr. Jacobs, if you want to speak to that a little bit, because that was a tremendous amount of time you spent.
Yeah, I would say that it was really a process of kind of co-creation. Obviously, the platform of Sentinel already had a lot of functionality that would work for home monitoring, but the responsiveness of the team at Sentinel to our needs has been really impressive. And as you note here, very nimble. Sometimes larger platforms and other organizations have a hard time moving that fast or really moving in ways that can help you. And so it was really record speed in which we were able to make this functional, thanks to Sentinel.
All right, so then we have contact tracing, right? And I'll be completely honest, and I've said this in numerous forums, I always knew about contact tracing and appreciated, the affect of it, but I had no idea what it actually makes to go into it, right? And again, grateful that we have the type of caliber individuals we have here, world-class people, and you'll hear from Dr. Bhavani a little later today. We were able to start looking at this and figure out, how do we do contact tracing? And it's amazing. There's even public articles out now of a lot of different public health authorities that still rely on fax machines and paper and pen. That is the prototypical contact tracing modality. Excel sheets, pen and paper, faxes. I mean, it's very 1990s. And so here, obviously, we wanted to go quick. We wanted to go fast. We wanted to have something that was a modern tool. So everything had to be digital. Everything had to be discrete data so that the maps and the dashboards was actionable, and we could take immediate affect on what do we need to do to get in front of this. So looking at it, Sentinel and Dr. Shah and team sat down and was able to sit down with Dr. Jacobs and team and really start mapping out what this would look like. But more importantly, it took a lot of conversation with the public health authorities, the CDC and others to figure out, what do you guys want to know, right? We were still learning about COVID-19. We're still learning about COVID-19, but particularly in the early days. And that's tough because now you got to figure out what questions you want to ask people, how far you want to go down with it, as well as how do we get consent? How do we make sure the patients are informed of what we're doing? How do we not terrify folks to think, oh my goodness, we have COVID-19. It doesn't mean this is a death sentence. How do we partner and do some innovative things? And Dr. Jacobs, I don't know if you want to speak to the clinical aspect of that.
In terms of contact tracing, I would just say it is one of the pillars of containing a pandemic like this, as Dr. Fauci reiterated yesterday. To be able to do it in a high quality manner, I think Dr. Bhavani really worked hard on this to allow us to be able to do this in a high quality manner that we could work to try to allow individuals to know that they were positive, who they contacted, and allow those individuals who were contacted to take care of themselves, their families, and their communities.
What was also interesting for all the technologists listening was the amount of work behind the scenes in the medical records that we had to do. The World Health Organization did release an ICD-10 code sometime about February timeframe for COVID-19. It's amazing the EMR vendors' reluctance to adopt those codes quickly. And so it took a lot of insistence on make sure this code is there so that way we could map for both home monitoring and contact tracing anyone as our patients as also COVID-19 suspected or positive. And so then came testing and test results and how do we incorporate that? And as you begin to see home monitoring, contact tracing, the nurse triage process, testing, all overlap. And if you think of concentric circles, they sit across each other so that way you can comprehensively take care of a patient to the best of your ability. And it gives folks like Dr. Jacobs an insight and a lens onto what's going on here, right? How do we make sure we get you quick resources in a way that's expeditious and that we're not wasting resources, particularly when in the early days PPE, and it still is, was in dire supply, particularly here in Austin. I don't know, Dr. Jacobs, if you want to speak a little bit to that.
No, I think that you're spot on there, Aaron, with the issues that we faced.
All right, so how did we go about this and what was important? So obviously in speaking with Dr. Shah, you know, and as he and Dr. Jacobs and Dr. Bhavani and team really worked through the clinical aspect of it, it was now, okay, sometimes companies are not a good fit for provider organizations for one reason or the other. So Dr. Shah and I and his entire team started sitting down going, how can we get to goal quickly? How can we make this successful so that, you know, we can stand up immediately home monitoring and on the heels of it, contact tracing? This is not an easy task. This is not easy to do, especially when you're also building the airplane in flight. As I said earlier, the operational processes, you're redesigning essentially your entire clinical practice. The medical school is still going on, but it's all virtual. What do we do? And so Dr. Shah said, hey, look, let's have a very agile, very fluid mechanism with you know, contract language and others that are modifiable and that we can work it together. And it's almost like a shared risk model of co-development. Nirav, if you want to speak a little bit to that.
Yeah, certainly. So, I mean, I think as we talked about initially, you know, we got basic paperwork out of the way, BAA and NDA, so that we could just start working on something together in good faith. And then from there, it was a collaboration, knowing that we also didn't know what we were about to do and trying to work through that sort of in good faith and on good terms with you and the team. So that's been great.
And one other thing I think was very, very important was you had folks like Dr. Jacobs and Dr. Bhavani and others bringing feedback directly from users of the system, some of the beta versions of the system. What are we seeing? We did shakedown tests, you know, immediate. Intelligently, the medical school students were scooped up and added to the part of the contact tracing team. So they were giving feedback. And so we had this, you know, iterative, here's the feedback loop, what's coming back to a sprint cycle. And then the team would meet almost daily around lunchtime for an hour and go through that and say, okay, this tweak or this thing or this field or this criteria. And on top of that, then also you have the clinicians interfacing with the public health authority and the CDC saying, okay, criteria just changed. We now need this, we now need that. That's tough, right? Because usually when you go buy something off the shelf, this is on the shelf and this is what you're going to buy and it does X, Y, and Z and it does it well. In this case, we were co-building something, which almost is unheard of with some of the larger, more established companies. And that's why partnering with a startup like Sentinel that got it out of the gate and said, nope, we're going to go in the boat together with you, made the most sense. All right, next slide. So what is the solution? Let's talk a little bit about it. And we're going to go through it in two pieces, right? Obviously the home monitoring component first, and then talk about contact tracing and how it works. Essentially, what you're seeing here is screenshots of the application itself. It has critical values built into it, so you can start seeing when somebody is a high fever or medium temperature, color-coded indicators. So some of that, you know, onset of clinical decision support is built into it. It very much ties to just about everything with a common API broker. So it made it very easy to tie our electronic medical record, some of the lab feeds and whatnot into it. And it just made sense. It just made sense for us and the way it was deployed. And it was across iOS and Android, which is very important to, especially to a tech city like Austin. Nirav or Liz, anything you want to say to that?
Oh yeah, I just wanted to add, if you note that there are also symptoms, I mean, as probably people know, less than 50% of people actually with COVID actually have a fever. And so it was really important to track the other symptoms and know other people's symptoms. And there's a functionality where actually people can say whether their symptoms are getting better or worse from the day before. And that can trigger, when you look at the dashboard, which I think Aaron's going to show you next, if I look at the dashboard, I can see if people's symptoms are getting worse, and that would indicate that someone needs to reach out to those individuals and talk to them. So that's what's great about this. And I also just want to note that it's also available in Spanish and very highly usable in Spanish as well.
Yeah, thanks for mentioning that. As far as sort of the language piece, which you just mentioned, you know, a third of our team is Spanish speaking, and we serve markets and patients in Phoenix, California, Texas. So it was a pretty important piece of how we had started designing Sentinel from day one, to serve different cultures and different backgrounds from a language and access to care perspective. But then in addition to what Aaron was just saying and Liz about symptoms and the biometrics, you know, with fever or with pulse oximetry, in our view, the challenge with a lot of these biometrics is they show up late. So fevers may be sensitive, but probably more specific for picking up an infection. And as we all now know, you know, there's less people who are diagnosed, you know, by that time, and there are many people who are asymptomatic. And so part of the goal of the dashboard was to take these subjective patient-reported symptoms and then use those alongside the biometrics, the objective data, if you will, to try and create a rules-based kind of decision process around triaging and diagnosis.
Exactly. So next slide here is the provider view, right? And so what was very important was to be able to trend, be able to look at things, and for folks like Dr. Jacobs to be able to react quickly to an issue that was going on. As was publicly noted, UT Austin had some somewhat, I guess, infamous cases of spring breakers chartering planes to Mexico. So we know that there were issues already in the community with just being a young town and people, you know, maybe not following isolation or social distancing rules, but they needed help, and we need to make sure their families are protected and the community was protected particularly. And so alerting and trending and being able to get in front of this stuff was very, very important. Politically, if you want to speak to that, Dr. Jacobs.
No, I think it's very similar. I just want to point out that if you can see, there's an area for symptoms, and that's where we can actually look at the symptoms where it says triage patients at risk. And that's where we can see if people are having cough, shortness of breath, those are the ones that we worry about most, or increasing persistent fever. So very helpful to us.
Dr. Shah, anything you want to add?
No, I think that's right. And I mean, it's hard to tell from the slide, but on the left-hand side where it has the symptoms, it helps you review whether the patient had the same symptoms or worsened severity or they're different. So you get a little bit more of a qualification around the symptom grading from the individual who's reporting.
Yep. All right, so what does a patient journey look like, right? So they have smart apps they can download. Also interesting, through this, we learned a lot of things like our indigent care population maybe had a smartphone, but they didn't have an access to an Apple store or the Droid store. And so we need to also have a web app interface as well. And so there were things that we learned in flight that were critical. Even the responsive design of the iOS or Android app was important, right? The layout, the look and feel, the simplicity of it. And as Dr. Jacobs spoke earlier to it, also to trust the app was having it multi-language, being in a native language that the patients spoke or read, so they understood what they were looking at and the importance of taking care of their own care, right? The whole point of this is engagement of the patient in a manner in which they feel the importance of entering in their information, tracking their temperature, tracking their own comorbidities, and reporting that to us so we can help them. And that takes a foundation of trust that Dr. Jacobs spent numerous hours working through, partnering with folks, and just understanding what do the patients want to see and how is that going to affect their ability to receive care. Dr. Jacobs, anything you want to add to that?
No.
Dr. Shah? Okay.
Nope, that's good.
Dr. Shah, anything you want to add to that?
No, that's not great.
All right. So then labs came into effect, right? I'm a patient. Let's say I've come through the COVID-19 drive-through for UT Health Austin. I have maybe a slight fever, but I have no idea if that's allergies. We have bad allergies here in Austin, FYI. There's like cedar fever here. It's very common. And so it's like, okay, do I just have cedar fever, or do I have an issue? So you get swabbed for a COVID-19 test. Well, those lab results eventually come in. We've got to be able to track those. Usually a lot of you have them go into your electronic medical record. Sentinel also has an ability to receive that. So we're able to see that patient Aaron who came through the COVID-19 drive-through, here's his lab, it's either positive or negative, and attaches then with a trend of my temperature, my self-checking temperature, right? And so we can see, okay, guess what? Aaron's temperature isn't about COVID, he's negative, so it's gotta be cedar fever. And so that was the important aspect of this, which I give a lot of credit to because it completed the picture for us without having to flip between multiple systems of what's going on. And again, all the data was available to us discreetly. Nirav, anything you want to add to that?
No, that's great. Thank you.
Yep. So next slide. All right. So what does it look like for a patient to be able to do this, right? We wanted to make it very simple for them. So they obviously download the app itself. They have their own PIN code, and then there's a lot of digital consents. I want to spend a little bit of time on consent because I think this was very important. And we spent a lot of time with our compliance and legal and public health legal to understand what kind of consent do you need to be able to do home monitoring, and what kind of consent do you need to do contact tracing. And then once they consent, then we're linked, right, between the two. We're able to monitor them. Dr. Jacobs, anything you want to add to that?
No, actually, someone just asked a question that I answered in the Q&A, which is that it was very easy from the clinician side to use this tool, but it is a little complicated, or has been a little complicated for the patients, just because you have to help them find where they put in their PIN code. But they can easily be instructed how to do it.
Mm-hmm.
Yeah, and on this note, I mean, because of some of the experiences we had here, we've started building up our own kind of resource and technology to help basically provide tech support in-app. Many of you might be familiar with sort of the team viewer experience for IT support, where they take a pin and they enter information, kind of take over the screen. So we'll be going live with this kind of this notion of what now is referred to apparently as co-browsing, which is a new buzzword from the Valley, where we can kind of share tech support and help these patients go live around these specific items, like entering PIN codes and where to enter it. Especially, you know, when we developed the original app, it was from my clinic in stroke care, where most of my patients had neurological damage. So it had to be designed in a way that was easy enough for them to use with big font, but there's still certain complexities, as we all know, as we kind of add more features and more product depth to it.
Yep.
So just for those who might be wondering about this on the call, that obviously our legal team worked with us to add some consent language. And when you swipe the button, or I don't know what you call that, Nirav, you need to talk about that. When you, on an app, when you basically say you consent, that was there, and that was considered adequate consent for us to have their clinical information and reach out to them and give them clinical guidance.
Yeah, the digital signature. Yeah,
the digital signature, or the click rapid consent, depending on who you ask. I mean, this was also important to me when I was in stroke practice. It was quite annoying for me to not be able to have family members get access to their patients' data. And also, we all know that consent's an important piece, even though if it's part of standard of care, it's just good to get patients have the ability, especially given all the news around privacy and concerns around, data breaches and Big Brother. So we wanted to make sure it was front and clear. But the nice thing is, and you guys can speak to this a little bit more because it's such a big topic, and it was something we discussed in detail. If there are different entities within a larger organization that have different frameworks around consenting, for example, whether it's students or patients or otherwise, we can easily kind of fill in the consenting language so that it's standardized and has that modern kind of digital signature feel.
Yep. And maybe it's academic medicine, but we have very thorough compliance and legal. So we spend a considerable amount of time going through this in every single word, every single bit of language. But again, credit to Dr. Shah and his team for working with us and getting us there. Because we must capture consent multiple times within the app for multiple different features and things that we do. We wanted to make sure that, above all else, which I really appreciate the clinicians ensuring, is that we're 120% transparent to the patient. They understand exactly what we're doing, why we're doing it, how we're doing it, what it's going to be used for, and how we do our best to protect them. And it's the only way this is successful. And that is, again, hats off to our clinicians for really taking the time to really want to work through that. All right, so let's talk about contact tracing, right? And this one was just fascinating because again, I had no idea what it takes to do epidemiology in this manner. It is amazing amount of work and mathematics and statistics and all sorts of things. So what was important was we capture the right data up front and looking at it to make sure that, you know, the important information, your address, phone number, who are your family members? Was it you that was exposed? Are there incidental exposure? And I mean, there's screen after screen of drill down. You know, I didn't want to put 1,000 screenshots on here and just bury you in screenshots. But at the top level, it is exactly what you think it is. It's basically a customer relationship management software specifically built for epidemiology. And to be able then to link back to, hey, you know, that person, Aaron, that we were monitoring for home monitoring, well, God, guess what? Now we're contact tracing him and his family. And so being able to go back and forth and see that lineage was very important. Dr. Jacobs, anything you want to add to that?
No, I think I'll hold my comments because I know that we need to wrap up, so I can answer those things in the Q&A. Got it. We're getting the buzz. All right. So looking at it also from a contact tracing perspective, you could see here, and this is a map of Austin, that it was able to be quickly visualized for us. Once we started getting the data in the system, we're able to really help the city of Austin articulate what's going on. We were able to then also dispatch our clinicians to be able to get in front of some of these things. I recall a phone call at like 6:30 in the morning on a Thursday in April where I heard that we were dispatching a team immediately to the Salvation Army because there had been an outbreak there of COVID suspected sickness. And so how do we get our clinicians into the field, right? You've got to be able to visualize quickly what's going on real time. Liz, I don't think anything you want to add to that? No? All right. And so what did we learn? A couple of big things. One, it takes true partnership and focus to get to something like this. As I've been alluding to the entire time, contact tracing is not easy. Not everybody is blessed with a Dr. Bhavani like we were and team, but it's not easy. And desperately, there's needing to be modernization and federal funding for public health in general. Clinicians and practitioners must be at the helm, as I've been saying. This must be of direct benefit for any feature we put out there to the patients. I said it over and over again, over-communicate. We did a lot of that, and we're still doing a lot of that. You have to be transparent. And you have to put a mandate out there, like no non-discrete data. It may be harder, it may be tougher, it may be easier to say, hey, just give me a PDF and fax it, fight that. Don't let that permeate, otherwise it will not be successful. Get your medical students involved. I think this was a brilliant move by the clinicians to do this. Not only did it involve the PG3s and 4s into something that was bigger than them and give them real world experience, but it also gave us additional hands and thought. And you'd be amazed at the youth of medical students and what the ways they think and the questions they ask has been invaluable. And then again, closely partner with area healthcare delivery organizations. And in our case, we have HCA, we have Ascension, we have Baylor Scott and White, and our clinicians didn't hesitate to say, hey, we can help you. We can help you do contact tracing for your patients that are suspected. We can help you do home testing. We can do all sorts of things to help you. As is the point of academic healthcare and what UT Austin strives for. It was a phenomenal way to partner because we had capability that maybe they just didn't have. Dr. Jacobs, I don't know if you want to say to that. All right. So what are our results? What have we done thus far? From April 23rd to present, we've traced 1,500 cases and over 3,500 contacts. In the last 5 weeks, we reached an average of 84% of the cases and 73% of the contacts, which is tremendous. You'd be amazed how many times you get to call somebody and pick up the phone. And of course, the goal overall is to increase the proportion of cases that were identified as contacts through contact tracing efforts. This will indicate fewer chains of transmission in the community that we just don't know about. And Dr. Bhavani can speak all to this in the Q&A upcoming because this has been a tremendously heroic effort. Liz, I don't think you want to add to that? No, I agree. It's a lot of work, but it's really important. That's all I have to say on that.
All right. And so I'm sure all of you will get this slide deck, but I put links to a lot of the fantastic interviews that our clinicians have been giving on contact tracing. What are we learning in flight? What I appreciate also about UT Austin is that we try to publish and teach as much as we practice. And so the rest of the world learns. So hopefully these articles and these interviews will help give you insight that maybe are applicable for your organization, institution, and then move the ball forward. But above all else, persist, get there, and don't give up.